Hello, my dear friends. Welcome back. This is Dr. Azam here, your faculty of anatomy at PrepLadder. So with this note, let's get started with the very first question here. Identify the cell marked in the histological image of the cerebellum as shown below. Now, this is like one of the hot favorite questions of the examiners for your INI-CET, my dear friends. Remember, in your INI-CET exam, my dear friends, please remember that cerebellum topic is very much important, and always every time they have always given you this picture, this image of the cerebellum, histological image, and there you have to identify the cell. Now first let me discuss the entire concept with you here. Now if this one here will be the outer part of the cerebellum, that is cerebellar cortex. Now the first point that you have to remember here, in the cerebellar cortex you're totally having three layers, and these three layers of the cerebellar cortex, in these three layers you'll be having 5 different types of cells. So there are 3 layers, and in the 3 layers you'll be having 5 different types of cells. Now this outermost layer here, this one will be referred to as the molecular layer, and this middle one here will be the Purkinje layer. This is the Purkinje layer, and the innermost one here will be the granular layer. That is a granular layer here. Fine. So as I told you, let us learn these 3 names again here, my dear friends. Remember, the outermost layer will be the molecular layer, the middle one will be the Purkinje layer, and the innermost one here will be the granular layer. Now out of this, remember, the molecular layer is the one which will be having the stellate cells and the basket cells. Purkinje layer, it will be having Purkinje cells. And then finally the granular layer is the one which will be having granular cells and the Golgi cells. So outermost molecular layer will be having stellate cells and basket cells, and the middle one, Purkinje layer, it will be having Purkinje cells. In the innermost one, the granular layer, it will be having granular cells and the Golgi cells. Now out of this, remember, the moment you look at this diagram here, you'll be easily able to identify, yes, the Purkinje cells here. Now this Purkinje cells, they'll be like flask shaped, and they are the largest one. If you see all the cells over here, out of all the cells, the Purkinje cells will be the largest one, and they're actually flask shaped. You have to even remember these 2 points also. Okay, that's the reason why they're like easy to identify, and always every time in your exams they'll be asking the same question. Yes, there will be a arrow mark on this one here, and you need to identify this Purkinje cells over here. So this has been like a repeat question in your INI-CET exam, so please try to remember that. Yes, the Purkinje cells, 2 points, remember, they're the largest one and they are having the flask shape. Now apart from that, certain other points also I want you to remember here. Remember, the stellate cells are inhibitory, the basket cells will be inhibitory, Purkinje cells are inhibitory, and even Golgi cells will also be inhibitory. The only excitatory cells here will be the granular cells. So we can say that the cerebellar cortex is actually the largest collection of inhibitory neurons. The cerebellar cortex is actually the largest collection of all the inhibitory neurons. Only the granular cells will be excitatory over here. So these are all the points that you have to remember about the cerebellar cortex, my dear friends. So once you know this one, yes, the moment you look at this diagram, you can clearly see the arrow mark is actually on those Purkinje cells. So therefore, the correct answer here will be the Purkinje cells. Next one. The long left recurrent laryngeal nerve is due to the persistence of which of the arch artery? Now please look at this question very carefully. We very well know right from the first year MBBS days that out of the right and the left recurrent laryngeal nerve, the left one will be more longer. But we know the reason with respect to the gross anatomy. Why? Because the right recurrent laryngeal nerve is going to take a turn around the right subclavian artery, whereas the left recurrent laryngeal nerve is going to take a turn around the arch of aorta. That is why we know that the left one is longer. But here in the question, they're asking it is longer due to which arch artery. That means the question is about gross anatomy, but the answer they're expecting you from the embryology part. So now please look at this diagram very carefully here. Yes, of course, we have discussed this in embryology that this one here will be the aortic sac in the front. Be careful, I'm not telling aortic sinus, I'm telling aortic sac. So there will be the aortic sac and you'll be having the dorsal aorta behind. So during development, there'll be like 2 dorsal aorta. One is the right dorsal aorta, another one is the left dorsal aorta. Connecting them, we're having totally 6 arch arteries. The 6 arch arteries. Now, if you look at this diagram here, in this diagram, this is the first arch artery. Okay, and remember the first arch artery is not going to form anything. There is no derivative of that one. There will be a remnant of that one, my dear friend. And the remnant of the first arch artery will be the maxillary artery. So maxillary artery is the remnant of first arch artery. Now this one here will be the second arch artery, and the remnant of this one here will be the stapedial artery and even the hyoid artery. Remember, these two will be the remnants, my dear friends. Repeat again. The remnant of first arch artery will be the maxillary artery, and the remnant of second arch artery will be the stapedial artery and hyoid artery. These two will be the remnants of the second arch artery, not the derivatives. Fine. And now welcome here the third arch artery. So the third arch artery, it is the one which will be forming your carotid arteries, my dear friend. Please remember, it is the one which is going to form carotid artery. If you are able to look at this diagram here, yes, you can clearly see the proximal part of this one is going to form common carotid artery. The proximal part is going to form common carotid artery, whereas the distal part is the one which is going to form the internal carotid artery. I mean to say the distal part of third arch artery along with dorsal aorta, it is going to form the, yes, internal carotid artery. Now after that, welcome to the fourth arch artery. The fourth arch artery on the left side, it is the one which is going to form arch of aorta. Be very careful, I'm telling you, only the left fourth arch artery is going to form arch of aorta, whereas the right fourth arch artery is going to contribute for the formation of right subclavian artery. Then after that, fifth arch artery, we know very well. Yes, my dear friends, remember, out of the 6 arches that we have, pharyngeal arches that we have, the fifth arch is the one which will completely degenerate. It is gone. So remember, nothing will be derived from there. And after that, finally, the sixth arch artery, the proximal part, it is going to form the pulmonary arteries. So pulmonary arteries are derived from sixth arch artery. And on the left side, you can clearly see the connection here. The pulmonary artery is attached to the arch of aorta with the help of ductus arteriosus. And ductus arteriosus, it means it is also derived from where? It is also derived from the sixth arch artery that on the left side. So it is derived from left sixth arch artery. It is derived from left sixth arch artery here, sir. Now, once you are done with this one here, my dear friends, remember, look at this diagram very carefully here. In this diagram, we can clearly see that the vagus nerve here, the yellow colored one here will be the vagus nerve. For example, if you're looking at the vagus nerve on one side here, this is the vagus nerve here. And that vagus nerve, it is giving rise to the recurrent laryngeal nerve here, the left recurrent laryngeal nerve here. Now on the right side, what is going to happen? On the right side, there will be no ductus arteriosus from here, and there will be nothing derived from the fifth arch artery. Therefore, the right recurrent laryngeal nerve, it's having the possibility of ascending up. It is going to ascend up. So no one is going to stop it here. No one is going to stop it here. So that is the reason why it is going to take a turn around this right subclavian artery. Whereas on the left side, what is going to happen? The ductus arteriosus, after the birth, it will be getting closed. And it will be closed to form a ligament there, and that is nothing but ligamentum arteriosum. Ligamentum arteriosum. And that is the reason why on the left side, the left recurrent laryngeal nerve does not have any chance to ascend up. So it is getting stuck there itself. So therefore, we can say that the left recurrent laryngeal nerve is longer because of the sixth arch artery. Because of the sixth arch artery. So nowadays in your exam, they're asking the question from where? They're asking the question from, yes, of course, they are actually asking the question from, I mean to say like gross anatomy there. But the answer they're expecting you is actually from the, yes, embryology part here in this one. So please remember, the left recurrent laryngeal nerve is longer because of which one here? Because of the sixth arch artery, my dear friends. Now, once you're done with this one here, a patient presented with vision loss. On radiological investigation, an aneurysm causing the damage to optic chiasma. So the damage is actually to the optic chiasma was noted. Which of the following arteries is most likely to be the artery that is causing the damage? Now, if you look at this diagram very carefully here, this is the optic chiasma in this diagram here. And remember, optic chiasma will be compressed by the aneurysm of anterior communicating artery, ACOM. So ACOM aneurysm is going to compress which one here? It is going to compress the optic chiasma. Whereas PCOM, the posterior communicating artery, if it is going to have an aneurysm, it is going to compress the oculomotor nerve, the cranial nerve number 3. It is going to get compressed by the aneurysm from PCOM, the posterior communicating artery. So my dear friends, remember, if there is actually the condition which is actually said here, there is a vision loss here, and then the aneurysm is causing the damage to optic chiasma, that means the artery has to be the anterior communicating artery. So please remember this, we have already discussed in our main videos also. I repeat again, if there is a ACOM aneurysm, that is going to compress optic chiasma, and if there is a PCOM aneurysm, that is going to compress the oculomotor nerve. Now moving ahead with the next one, a 34-year-old man presented with fever, massive splenomegaly. On palpation, the spleen was 15 centimeter and directed obliquely when measured from the right iliac fossa. Which of the following structures prevent the vertical and downward descent of the spleen? So please remember, my dear friends, whenever you look at the spleen here, the vertical and downward displacement of the spleen is prevented by this ligament that is between the colon here and the diaphragm here. And for diaphragm, we'll be using the word as phrenic, and for colon colic, phrenico-colic ligament. So this phrenico-colic ligament is the one which is responsible for, yes, preventing the spleen from descending downwards. So therefore, the correct answer here will be the phrenico-colic ligament. Apart from that, in the spleen, actually not many questions are asked in your exams, my dear friends. Other things we know very well. There'll be the odd rule, the rule of odd, odd rule of, we will actually call it as Harris dictum also. Like 1, 3, 5, 7, 9, and 10, and 9 and 11. It will be like 1 inch in thickness, and then 3 inches in width, and then 5 inches in the length, and then 7 ounces in weight. 7 ounces. I'm not telling grams and all. I'm telling 7 ounces in weight, and it'll be extending from 9th to 11th rib. The spleen is going to extend from 9th to 11th rib. So there is a rule of odd numbers and all those things we know very well. But remember, the downward displacement of the spleen when there is a splenomegaly is prevented by phrenico-colic ligament. A chronic tobacco consumer went to the dental clinic with the bleeding lesions on his tongue and was diagnosed with carcinoma of tongue. Which of the following papillae which do not have taste bud? That is a hint here. Which of the following papillae which do not have the taste bud is likely to be involved in such cancer? Now, what is happening is in the INI-CET exam, what I've observed recently, my dear friends, yes, of course, there used to be a question from tongue topic, but previously it used to be from muscles of tongue and nerve supply to tongue. Especially from the nerve supply to tongue, like general sensation, special sensation. So from the muscles of the tongue and nerve supply to tongue, they used to ask the questions from there in your INI-CET exam. But recently, from last 1-2 years, they started the trend of asking the questions about the papillae of the tongue. So let me tell you all the points regarding this one. We know very well on the surface of the tongue, you'll be having fungiform, circumvallate, filiform, and foliate papillae. Fungiform papillae, from the name itself, we can understand they're like mushroom shaped. If you look at this diagram here, the second diagram here, my dear friend, you can clearly see that they are like mushroom shaped here, fungiform, and they contain the taste buds, fine. And then second point is circumvallate. This is something really important. Many questions will be coming from here. First of all, they are like large circular papillae. They're like large and circular papillae. But the most important thing, how to identify them, is actually by that groove. Please look at this diagram here. In this diagram, you're able to see that there is a groove, or we will call it as trench. So if you look at the circumvallate papillae here, on either side, you'll be able to find this groove or this trench here. It is a large and circular papillae, and they are present right in front of that, the line which is separating the anterior 2/3 of the tongue and the posterior 1/3 of the tongue. So I hope you remember, whenever we draw the diagram of tongue like this here, conventionally we'll divide the tongue into the anterior 2/3 and posterior 1/3. Anterior 2/3, yes, this is the place exactly where you have the circumvallate papillae. And from the anterior 2/3 of the tongue, the taste sensation will be carried by the facial nerve, chorda tympani branch of the facial nerve. Who doesn't know that one? So from the anterior 2/3 of the tongue, taste will be carried by chorda tympani branch of the facial nerve, except for circumvallate papillae. Now remember, even though they are present in the anterior 2/3, from the circumvallate papillae, the taste sensation will be carried by 9th nerve, the glossopharyngeal nerve. The taste sensation will be carried by the 9th nerve, glossopharyngeal nerve, guys. So they are identified by that circular groove, or there is a trench on either side. Now welcome to the filiform papillae. Filiform, like from the name itself, we can understand they are slender, thread-like papillae, but they don't have the taste buds. Important point to remember. And one more point that you have to remember is that normally these papillae, they should be having the stratified squamous epithelium, stratified multiple layered. And squamous epithelium, of course, in the mouth, we are having like wear and tear, we are eating the food and all those things. So you should normally be having stratified squamous epithelium. But it should be keratinized or non-keratinized. Remember, it should be like non-keratinized. Of course, makes sense. Keratinized stratified squamous epithelium is present on the surfaces, like, on the skin and all. But it should be non-keratinized when it comes to the oral cavity here. But filiform papillae is the one which will be having stratified squamous epithelium, that too keratinized. Another important point to remember. So I want you to remember like 2 points regarding the filiform papillae, that there are like no taste buds in that one, and they'll be having keratinized stratified squamous epithelium. And foliate papillae not like very well developed in adults. They're like well developed in the early childhood. So not many questions will be asked from there. So please be ready in your exams for the questions from circumvallate papillae and the filiform papillae. So therefore the correct answer here, which will not have the taste buds, that will be the filiform papillae. A patient underwent coronary bypass graft with a great saphenous vein. Okay. The patient now complains of paresthesia and sensory loss over the medial aspect of the leg and the foot. Okay. So which of the following nerve is most likely to be involved in this condition? So remember, in CABG, we'll be commonly using a great saphenous vein. And along with this great saphenous vein, what is going to happen? Saphenous nerve is the one which is going to travel. Along with the great saphenous vein, the saphenous nerve is going to travel. Saphenous nerve is actually a branch of your femoral nerve. And that saphenous nerve is the one which is supplied to the skin of the medial side of the leg as well as medial side of the foot up to the ball of the great toe. So saphenous nerve is the one which will be supplied to the skin of the medial side of the leg and medial side of the foot up to the ball of the great toe. And remember, yes, of course, if in CABG, if you are going to use in CABG, if you're going to use that great saphenous vein, when you're going to remove that one, when you're going to do the veiny section, so there are high chances that saphenous vein is gone, and saphenous nerve will be gone, and the patient is going to complain of loss of sensation on the medial side of the leg and the foot. Medial side of the leg and the foot, guys. Now identify the cartilage given below. Now, my dear friends, of course, in your exams, there'll be like one question from histology in your INI-CET exam and all. And in histology, remember, most of the time what we have observed, whether it is NEET PG or INI-CET, always there'll be a question from epithelium or cartilage. At least you should be knowing this one for sure. So now let me clarify regarding the cartilage here. We know very well the cartilage will be of three types: hyaline cartilage, elastic cartilage, and the fibrous cartilage. Hyaline, elastic, and the fibrous cartilage. Now, how to, like, first of all, differentiate? If the image is given to you, how to identify the hyaline, elastic, and fibrous cartilage? Only 2 points, my dear friends. Number one, you're going to look at the cells here. First, look at the cells here. Okay, of course, the cells present inside the cartilage will be known as chondrocytes. They're like chondrocytes. So, the chondrocytes, if they are present in groups, you can see here, if the chondrocytes are arranged in groups here, if they are arranged in groups over here, then it should be hyaline cartilage or elastic cartilage. Hyaline or elastic, they'll be having chondrocytes arranged in group, whereas fibrous cartilage will be the one which will be having the chondrocytes arranged in rows. Will be arranged in rows over there. Fine. Now the problem here, sir, if they are arranged in rows, we can easily identify that it's fibrous cartilage. But what about if they are in groups? How to differentiate the hyaline and elastic? Remember, now you have to look for the second point, that is matrix. If you look at the matrix here in the hyaline cartilage, the matrix is very clear. From the name itself, we can understand hyaline. The word is coming from hylos. Hylos, glass-like, transparent, shiny. It is glass-like. So therefore, there is a hyaline cartilage. And if the matrix here is having those branched fibrous elastic elastic fibers present over there, they'll be like branched and all. There'll be short and branched elastic fibers present there, and with the help of those fibers you can easily identify, yes sir, this one here will be the elastic cartilage. So let me tell you again here, neat and clearly, my dear friends, whenever you get a question in your exam about the cartilage, like remember two things here. Point number one, you have to look for the chondrocytes, the cells. And point number two, you have to look for the matrix. If the chondrocytes are arranged in a group, it can be hyaline or elastic. And then how to differentiate? Look at the matrix. If the matrix is like very plain, transparent, shiny, glass-like, then it is hyaline cartilage. If the matrix is having elastic fibers, which are like short and branched fibers, then it will be elastic cartilage. Whereas suppose if you are lucky on that day of the exam, they'll be giving you fibrous cartilage, and that is the easiest one to identify. The chondrocytes will be arranged in rows, and in the matrix, the fibers are also like very well arranged. So my dear friends, it is easy to identify here. Identify the cartilage given below here. It is actually the fibrous cartilage. So therefore, option number one, hyaline, it can't be hyaline cartilage. It can't be the yellow elastic cartilage. Remember, the correct answer here will be the white fibrous cartilage. Which artery is used for arteriovenous shunting with a great saphenous vein for hemodialysis, and that is located behind the medial malleolus and 2.5 centimeter in front of the tendocalcaneus. Look at this one here. Now this one here in this diagram is tarsal tunnel. In the tarsal tunnel, you'll be actually having three important tendons passing from here. The tendon number one will be of tibialis posterior. Number two, flexor digitorum longus. Number three, the flexor hallucis longus. There'll be like three tendons passing from here. Along with that, the nerve which is going to pass from here. I told you this many times when we learned about the lower limb topic in our golden rule itself. Remember the nerve that is coming from behind, which is supplied to the posterior compartments. The posterior compartment of thigh, the posterior compartment of leg, it is supplied by tibial nerve. So tibial nerve is coming from behind and it is going to take a turn and then enter into the foot there. So of course, the nerve which is going to turn here, this one here will be the tibial nerve. And the artery which is passing from here will be the posterior tibial artery. The posterior tibial artery. And yes, of course, it is present between the medial malleolus here and the tendocalcaneus here. Medial malleolus and tendocalcaneus, the tendon, calcaneal tendon I can say, which is also referred to as Achilles tendon. Okay. So in between them, we have this artery that is nothing but the posterior tibial artery. That is the artery which is actually mentioned here. So the correct answer here will be the posterior tibial artery. Moving ahead with the next one here, what is the nerve supply of the following labeled muscle? The important thing in this question, why I have given you is that you should be able to identify the muscle first of all. You should be able to identify that muscle. That is the important thing. After that, nerve supply you can easily tell here. Now in this diagram, the muscle that you're able to identify here, this A here stands for the anterior belly of digastric, and this B here will be actually the posterior belly of digastric. So the anterior belly of digastric and the posterior belly of digastric, my dear friend. Now these two, they'll be supplied by, how to recall the nerve supply? Remember, recall the nerve supply from the pharyngeal arches I told you. Arch number one, the nerve will be the mandibular nerve, and mandibular nerve is the one which is supplying to all the muscles derived from the first arch, arch number one. And of course, the arch number two, that is the facial nerve, which is supplying them. And all the muscles derived from there will be supplied with the facial nerve. Anterior belly of digastric is the muscle which is derived from the first arch. First arch, it should be supplied with the mandibular nerve. And to be more specific, it is supplied by nerve to mylohyoid. Nerve to mylohyoid. And of course, the posterior belly of digastric, that is derived from arch number two, pharyngeal arch number two, and that will be supplied by facial nerve. So in that way, the nerve supplied to these muscles you can remember easily if you remember the pharyngeal arches and the derivatives of that one. Now moving ahead with the next question. A 50-year-old man sustains a minor cut while working with a metal sheet. The injury is located on the medial aspect of his palm near the wrist. Okay. So the injury is near the medial aspect of the palm and that too near the wrist here, near the wrist on the medial side with a metal sheet. He complains of numbness over the little finger and half of the ring finger. So the little finger and half of the ring finger. We know very well this is supplied by ulnar nerve, medial 1/2 digit. There is no motor weakness. Okay, that is also something important. There's no motor weakness of the fingers. That means all the muscles are actually intact. Which of the following structure is most likely to be injured? See what happens here when the ulnar nerve will be coming here. We know very well, we have learned in the entire course of the ulnar nerve. The ulnar nerve will be actually dividing into two branches. It is going to first of all pass superficial to flexor tenaculum. आपको याद होगा मैंने बताया था आपको ulnar ऊपर करके. कैसे याद रखना होगा हमको ulnar ऊपर. So ulnar nerve is going to pass superficial to flexor tenaculum. And after passing from here, entering into the hand, here it is going to divide into superficial branch and deep branch. Superficial, हमेशा मैं आपको कहता हूँ याद रखिए, superficial branch नाम में ही लिखा है ऊपर होगा ना, superficial ही होगा और वो skin को supply करता है. It is the one which is supplied to the skin there, है ना? Always remember how the doctors have given the naming there. So the superficial branch of the ulnar nerve, अगर आपको exam में याद भी नहीं आ रहा है, see, first of all, from the explanation here, we can easily understand the medial 1/2 digit is ulnar nerve. Fine. So you can clearly see ulnar nerve here, ulnar nerve here, ulnar nerve here. Fine. First of all, you can rule out radial nerve. You can rule out the dorsal branch of ulnar nerve. Nothing like that. We have deep branch and superficial branch. अब confusion यहाँ पर ये होगा. The confusion here will be, is it superficial or deep? Of course, the skin will be supplied by the superficial branch. So this is the one which we have, which is actually injured there when there is a minor cut with the metal sheet near the medial aspect of the wrist. Which among the following muscles are supplied by deep branch of the peroneal nerve? Now just recall the golden rule that I taught you in the lower limb. So in the thigh, you'll be having like three compartments. Anterior compartment of thigh is supplied by femoral nerve. The medial compartment of thigh is supplied by obturator nerve, and the posterior compartment of thigh will be supplied by the sciatic nerve. And then when it comes to leg region, in the leg region, posterior compartment of the leg, that is your calf muscles, are taken care by tibial nerve, whereas the lateral compartment of the leg is supplied by superficial peroneal nerve and anterior compartment of the leg by deep peroneal nerve. So deep peroneal nerve will be supplying to anterior compartment of leg. So it is the one which is supplying to all the muscles present in anterior compartment of leg. Now just try to recall. Do you have tibialis anterior there? Yes, of course, it will be supplying to tibialis anterior. And in the anterior compartment, will be having extensor muscles. That is extensor hallucis longus, extensor digitorum longus also. And then what about peroneus longus and peroneus brevis? They are present in the lateral compartment of the leg, not in the anterior. Of course, peroneus tertius is present here. Fine. So remember, the deep peroneal nerve is supplying to A, B, and D. So option A will be the right answer here. A 40-year-old male with the nasopharyngeal carcinoma presents with trismus and pain near the infratemporal region, locked jaw. Which cranial nerve is most likely to be involved here? Now, first of all, let me tell you, in the locked jaw, the muscle that will be involved will be the medial pterygoid one. And all the muscles of mastication, we know that will be supplied by mandibular nerve. That is your 5-3, mandibular division of trigeminal nerve. Fine. That's the answer for this question. We know that very well. Fine. But remember, my dear friends, like, yes, of course, in your INI-CET exam, these examiners are like mad about muscles of mastication. If you ask me today also, sir, just tell me like one question which is going to be like, sure, definitely, I want to gain that mark for sure. Remember, it will be muscles of mastication. Please learn muscles of mastication and go to the exam, INI-CET exam. Yes, of course, there will be a question from muscles of mastication. So it's better. We'll revise all the points regarding this one. There are totally like 4 muscles of mastication. We know that very well. Number one, this one here will be the masseter here. Masseter is attached to this angle of the mandible from the outer side. And this one here will be the temporalis muscle here. And then this one here will be the lateral pterygoid. And this one here will be the medial pterygoid muscle. So there will be masseter, there will be temporalis, and then you'll be having the lateral pterygoid muscle and the medial pterygoid muscle. Easy to identify. Why? Because lateral pterygoid muscle is the one which will be attached to the capsule of that temporomandibular joint. The capsule of temporomandibular joint that will be attached with lateral pterygoid muscle. Perfect. Now out of this, let me tell you like one question from here itself. Temporalis muscle, the horizontal fibers, I mean to say the posterior most fibers, horizontal fibers, when they are going to contract, they are going to pull the mandible behind. So that means they are helping in retraction. And remember, the vertical fibers here, they are the one which will be actually helping in elevation. So from here, we can remember that, yes, of course, temporalis muscle actually has got like 2 functions. One will be the retraction, another one will be the elevation. But in the exam, recently in one of the exams, they have given both the option. So when both the options are given, which is more better? Remember, temporalis elevation will be more better than retraction, because more number of fibers are actually helping in elevation when compared to the retraction. So elevation is better answer when compared to retraction. Now, what is the nerve supplied to all the muscles of mastication? Remember, it will be supplied by mandibular nerve 5-3. The mandibular nerve will be having 2 divisions. One is anterior division, another one is posterior division. And of course, it will be also having the trunk. Remember, anterior division will be supplying to all the muscles of mastication. Except which one here? Remember, except the medial pterygoid muscle. And this medial pterygoid muscle, it is the one which will be getting a direct branch from the trunk of the mandibular nerve. That is something really, really important. I repeat again. Mandibular nerve will be first having trunk, and the trunk will divide into anterior division and posterior division. Anterior division will be supplying to all the muscles of mastication except for the medial pterygoid. Why? Because medial pterygoid is the one which will be getting a direct branch from the trunk of the mandibular nerve, which is the only muscle helping in opening the jaw or depression of the jaw. That is nothing but lateral pterygoid muscle. Remember L for lateral pterygoid, L for lowering the jaw. It is the one which is helping in lowering the jaw. Which is the only muscle helping in retraction of the mandible? Just now I told you, temporalis. Most commonly involved in trismus. Remember, trismus is actually locked jaw. Locked jaw, mute. Mute, remember, medial pterygoid. So that you don't have a confusion between these two, lateral and medial pterygoid. And which is the accessory muscle of mastication? This one will be the buccinator muscle. Buccinator muscle. So in this manner, I have shown you all the images there so that you'll be able to identify the image-based questions. Apart from identifying the image-based questions, I have given you all the points which are required about the muscles of mastication. Now moving ahead, a 45-year-old man presents with a waddling gait and difficulty climbing the stairs. Waddling gait. On physical examination, when he is asked to stand on his right leg, his pelvis drops on the left side. Which of the following structure is most likely injured? Yes, Trendelenburg sign. And we know very well in this one, the nerve that will be involved here will be the superior gluteal nerve. And superior gluteal nerve is the one which will be supplying to two muscles. One is gluteus medius, another one will be the gluteus minimus. So when the Trendelenburg sign is positive, what is going to happen here? The superior gluteal nerve will be injured and these two muscles will be involved. The gluteus medius and minimus will be involved. When the person is actually standing on the right foot, left foot is off the ground, the left side of the pelvis will drop as given in the question. When the left side of the pelvis is dropping, when it is sagging, so remember, it's actually contralateral side superior gluteal nerve involved. That means the right side superior gluteal nerve will be involved there. So the correct answer here will be the right superior gluteal nerve will be involved here. Perfectly done. A forensic report of a fatal head injury mentions fracture at the Pterion, the associated epidural hemorrhage. Which cranial fossa in this region is closely related to that one? Pterion, you remember very well, it is actually a H-shaped suture. You can see in this picture here. When there is a hit in this region, remember, just inside this pterion here, you'll be having the middle meningeal artery. To be more specific, it is the anterior division or frontal division of middle meningeal artery. So if there is a hit here, of course, the middle meningeal artery will be ruptured. And whenever the middle meningeal artery is gone, remember, it will lead to epidural hemorrhage. A rupture of middle meningeal artery will lead to epidural hemorrhage. You remember that with that idli shape or biconvex shape hemorrhage, and then that lucid interval will be present over there. So that epidural hemorrhage, the question here is that it is present in which cranial fossa? So remember, if there is a hemorrhage here, that will be present in the middle cranial fossa because the pterion is actually corresponding to your middle cranial fossa. Now let us discuss all the points regarding the pterion, my dear friends. Another very important concept for your exam. Remember, pterion is actually H-shaped suture and it is formed between the four bones. Number one, frontal bone here. Number two, the parietal bone here. Number three, the squamous part of the temporal bone here. And this one here will be the greater wing of sphenoid. Greater wing of the sphenoid bone here. Now, nowadays in your exam, the most important thing is about the relations of pterion. What are the structures that you find just inside the pterion? As I told you, there will be anterior division or the frontal division of middle meningeal artery. And of course, here itself, you'll be having your brain present. And in the brain, if this is the frontal lobe here and temporal lobe here, between these two, this sulcus here will be the lateral sulcus or sylvian fissure. And the stem of that, the beginning of that, that is also present right at the pterion. So just inside the pterion, you'll be having the lateral sulcus or the sylvian fissure. And apart from that, in that lateral sulcus or in that sylvian fissure, remember, my dear friends, you will be able to find the middle cerebral vessels also. And then, of course, I told you that the pterion is actually formed by the greater wing of the sphenoid. It is formed by the greater wing of the sphenoid. But remember, inside that, you'll be having the lesser wing of sphenoid, the lesser wing of the sphenoid. And I don't even have to tell you the clinical correlation. Just now we have discussed that one. If there is a hit at this pterion, of course, the artery which is ruptured will be middle meningeal artery, and rupture of that artery will lead to epidural hemorrhage. Done. A 60-year-old patient presents with the pain and difficulty in moving the hip after sustaining a fracture in the proximal femur. X-ray shown below, which of the following movement is most likely lost due to the injury? First of all, if you look at this X-ray, the point which is marked here, yes, that is nothing but the lesser trochanter of the femur. And at the lesser trochanter of the femur, two muscles are going to get attached. One is iliacus, another one is psoas major. And these two together, they are going to form a common tendon. That is why in certain books, it will be referred to as iliopsoas. So lesser trochanter, it will be iliopsoas, it will be inserted over there. Fine. Now, this muscles, what is going to happen? If there is a fracture over there, if these tendons are not getting attached over there, then of course they are present in the front. When they are going to contract, that will be helping in flexion at the hip joint. So remember, there will be loss of flexion at the hip joint. Loss of flexion at the hip joint. Next one. Which of the following structures are derived from the neural crest cells? Now, neural crest cells, it's another really important topic for your INI-CET exam, one of the hot favorite topic, I should say. And if you look at this diagram, you should be able to first of all identify here the outermost layer here. This one will be ectoderm. This layer here on the inner side here will be the endoderm, and this one in the middle here will be the mesoderm. And this structure over here will be the notochord. This one here will be the notochord, and just above the notochord, my dear friends, you are able to appreciate the neural tube here. Now this one here will be the neural tube, and this, if this is the neural tube, just adjacent to the neural tube here, it will be having cells, and these cells are the one which will be referred to as neural crest cells. First, you should be able to identify the neural crest cells, my dear friend. The neural crest cells are present on either side of the neural tube. First, you should be able to identify the neural crest cells, because even that image-based question has been given in your exam. Now, this neural crest cells, they are the one which are going to form your peripheral nervous system. So remember, they are going to form all the ganglions as well as the enteric plexus. This is something really important. Schwann cells are also derived from the neural crest cells. In adrenal gland, remember, you'll be having outer part adrenal cortex, inner part will be medulla. Adrenal medulla will also be derived from the neural crest cells. Parafollicular cells, which are found in the thyroid gland, which is also referred to as C cells, they are also derived from the neural crest cells. In certain books, it is given wrongly. I mean to say the MCQ guides and all. In certain books, it is given wrongly that the parafollicular cells are derived from ultimobranchial body. Remember, my dear friends, it's a wrong thing. Ultimobranchial body, let me clarify here, it's just acting like a platform. The neural crest cells are going to migrate. They're going to migrate and come and sit on the ultimobranchial body, and then they're actually going to form the parafollicular cells. That's the reason why we can say that the neural crest cells are going to form the parafollicular cell just sitting on that ultimobranchial body. It's not derived from ultimobranchial body. Then remember, neural crest cells are also going to form melanocytes, and then in the head and neck part, they're like most of the things form. I mean to say the most of the skull bones, the dentine, the pharyngeal arch cartilages, and even the dermis of head and neck part, all these are derived from neural crest cells. Even this has been asked in the INI-CET exam, the conotruncal septum. And we know that it is made up of two septum. One is the spiral septum, another one will be the bulbar septum. So the spiral septum and the bulbar septum will be together referred to as conotruncal septum. Conotruncal septum. So in this list of derivatives from the neural crest cells here, whatever I have marked there, star marked, that one has to be like definitely known. You should know that for sure, because many of the times in your exams, they're asking the questions from there itself. Now coming back to this one here, what are the structures derived from the neural crest cells? Of course, the Schwann cells. Of course, the odontoblast will also be derived from here, and even the parafollicular cells are also derived from here. A, C, and D. Option B is right here. Not the retinal pigment epithelium, that is not derived from the neural crest cells. A 35-year-old man presents with weakness in his right hand after a penetrating injury of the forearm, and on examination is unable to make OK sign with his thumb and index finger due to weakness in the flexion of interphalangeal joint of the thumb and distal interphalangeal joint of the index finger. Fine. He is unable to make the OK sign. It is one of the old questions we know very well. Of course, what is the nerve that should be involved here? It should be your median nerve branch, that is your anterior interosseous nerve. The branch of the median nerve that is supplying to the muscles over here, that is anterior interosseous nerve. A newborn presents with fecal discharge around the umbilicus since birth. On examination, there is a patent connection between the ileum and the umbilicus. Which of the following embryological remnant is most likely responsible for this condition? If this one here will be the embryo, the outer body wall of the embryo, and we know that the body wall of the embryo will be derived from ectoderm, and this one here will be the endoderm, and endoderm is the one which is going to form the entire gut of the embryo. So this one here will be the foregut, the midgut, and the hindgut. The midgut extension here, vitello-intestinal duct, and from the hindgut, the extension here, this one will be the allantois. That is allantois. Now, normally in you and me, what should happen is vitello-intestinal duct should be completely gone. If this vitello-intestinal duct remains persistent, then what is going to happen? Of course, the fecal discharge will be coming out from the umbilicus. So therefore, the correct answer here will be the vitello-intestinal duct. It is the one which is going to connect that midgut to the umbilicus. Now, sometimes what will happen, the entire vitello-intestinal duct is not persisting, only the proximal part of that will persist, and this is actually referred to as the Meckel's diverticulum. Meckel's diverticulum. So I repeat again, if the entire vitello-intestinal duct is persisting, then we'll be able to see that meconium, the fecal discharge around the umbilicus, and if only the proximal part of that is persisting, then it will be referred to as Meckel's diverticulum. Meckel's diverticulum. Which ligament must be navigated carefully during the distal pancreatectomy to avoid the injury to the splenic artery? Now, if you look at this diagram, we have discussed this many times, my dear friend. Now, it is mentioning about the splenic artery here. So remember, splenic artery is actually the content of the splenorenal ligament here. You can clearly see this ligament between the spleen and the kidney behind, the splenorenal ligament or linorenal ligament. And that is the ligament which is actually allowing the passage of the splenic artery here. And of course, you can get the answer from here that the correct answer here will be the linorenal ligament. So which ligament must be navigated carefully during the distal pancreatectomy to avoid the injury to splenic artery? Why? Because that is the same ligament where you also have the tail of the pancreas present over there near the linorenal ligament. That is the reason why, remember, that has to be navigated very carefully. A newborn present with cyanosis and a continuous murmur is actually heard best at the left upper sternal border. Imaging reveals the patent ductus arteriosus. From which embryological structure is this vessel derived? I told you in the beginning itself. Ductus arteriosus will be derived from the left sixth arch artery, that to the distal part of that one. Okay, so sixth pharyngeal arch artery, this is the one which is going to form ductus arteriosus, that to the distal part of that. Proximal part is going to form pulmonary arteries. I have shown you that in the diagram there. Which of the following serves as the axis around which the midgut undergoes its characteristic 270-degree counterclockwise rotation during embryological development? See, we know very well that the foregut is going to rotate 90 degrees in clockwise direction, and the midgut is going to rotate 270 degrees in anti-clockwise direction, and hindgut is not going to rotate. Now this midgut is going to rotate 270 degrees anti-clockwise direction around an artery, the artery which is supplying to midgut. And which artery is supplying to the midgut? That is superior mesenteric artery. The superior mesenteric artery here. Next one. Another important concept right now. A 22-year-old male presents to the emergency department after a straddle injury. Straddle injury, riding the bicycle on the bumpy road. Sustained while falling onto a bicycle crossbar. Examination reveals a tense, swollen scrotum on the lower abdominal wall. A retrograde urethrogram confirms a rupture of the bulbar urethra. Rupture of bulbar urethra. Fine. On further evaluation, it is noted that the urine has not extravasated into ischiorectal fossa. Which structure is preventing this one? Now, my dear friends, first let me tell you here, nowadays whether you are going to attempt any exam, whether it is NEET PG or INI-CET exam, this concept is very much important, extravasation of urine. And here we used to learn, like 1-2 years back, we used to learn that if there is an injury to bulbar urethra or membranous urethra, where is the urine getting extravasated out? But remember, you also have to remember where urine cannot go and what is the reason for that one. You can see in this question here. Not only just remembering that where is the urine going, remember, you actually have to remember where is the urine cannot go and what is the structure which is preventing that one. Now I want you to remember like two important clinical condition here. Number one will be the straddle injury, riding the bicycle on the bumpy road. And second thing will be the pelvic fracture. This is the key word. And the first point that I want my students to remember is that whenever there is a straddle injury, the urethra which will be ruptured will be bulbar urethra. And whenever there will be pelvic fracture, the urethra that is ruptured will be the membranous urethra. If bulbar urethra is ruptured here, you can see in the first diagram, my dear friend, the urine will go out into the superficial perineal pouch. The urine is going into the scrotum. The urine will also go into the penile shaft as well as into the anterior abdominal wall. So therefore, in the straddle injury, what is going to happen? The urine is going into the superficial perineal pouch, into the scrotum, the penile shaft, and the anterior abdominal wall. And if suppose the membranous urethra is ruptured, the urine will actually extravasate out into the deep perineal pouch. It is going into the deep perineal pouch here. And not only that, the urine can go into the space around the neck of the urinary bladder. I mean to say that around that prostate gland, which is just behind the pubic symphysis there. And that space is actually referred to as the space of Retzius. Okay. So therefore, if the membranous urethra is ruptured in pelvic fracture, the urine can go into the deep perineal pouch as well as the space of Retzius. And finally, where the urine cannot go, that is also very much important nowadays. The urine cannot go into the thigh. The urine cannot go into the thigh. Why? Because of fascia lata. The urine cannot go into the deep perineal pouch due to the presence of perineal membrane. And similarly, the urine cannot go into the ischiorectal fossa also due to the presence of Colles fascia. And that is what is the question asked here. The urine cannot go into the ischiorectal fossa because of which structure? Because of the Colles fascia. There is nothing but the superficial fascia present in the perineum region. So I've discussed the entire concept here. Please remember the important key point, the key word here is that whenever there is a straddle injury, bulbar urethra will be ruptured. And whenever there is a pelvic fracture, the membranous urethra will be ruptured. And you have to remember where the urine is going and where the urine is not going. Now, which of the following is the branch of the posterior division of internal iliac artery? Now, in this diagram, you are able to see this one here will be the internal iliac artery here. The internal iliac artery is going to divide into two divisions. One is anterior division, another one is posterior division here. The posterior division will give rise to like three branches. Remember with the mnemonic as SIL. Silk, whatever. S stands for the superior gluteal artery, I for iliolumbar artery, and then L stands for the lateral sacral artery. S for superior gluteal artery, I for iliolumbar artery, and then L stands for the lateral sacral artery. And remember, there are like many branches given from the anterior division. And the advice here will be like after completing the entire subject, first of all, after learning all the important concepts, then if you still are left out with time and energy, then you can go for this one. Otherwise, learn the branches given from the posterior division more than enough. Why? Because always in the exam, the question will be in a similar manner. Which of the following is a branch? All of the following is a branch except one, something like that. Okay. So which of the following is a branch from the posterior division? Superior gluteal artery is a branch from the posterior division. SIL branches. Next one, my dear friend. A patient undergoes a skull base surgery and the surgeon identifies a foramen located between sphenoid bone anteriorly, temporal bone laterally, and occipital bone posteriorly. Okay. That means the foramen present between the three bones. Now in this diagram, if you look here, this is the sphenoid bone, body of the sphenoid bone. And this one here will be the temporal bone. To be more specific, that is the apex of petrous part of the temporal bone. And this one here, occipital bone here, basilar part of the occipital bone. And between these three, the foramen that you're able to see here, that will be the foramen lacerum. So foramen lacerum is present between the sphenoid and the temporal and the occipital bone. So therefore, which foramen are we speaking about here? We are speaking about the foramen lacerum. In fact, to be very frank with you, my dear friends, remember foramen lacerum is not like a proper foramen. It's not like a proper opening. It's just like a space which is left between the three bones. So between that sphenoid and the temporal and occipital, between those three bones, there's a space left, and that space is nothing but your foramen lacerum. Fine. Next one. During the laparoscopic cholecystectomy, the surgeon carefully identifies the Cartilage triangle and which structure does not form the boundary of the Cartilage triangle. I hope you remember that mnemonic. Normally, I don't like the mnemonics and all, but most of the students will be learning with that one. C for Cartilage triangle, and all the boundaries are with C only. So the Cartilage triangle is present between the cystic artery and then the common hepatic duct, and then remember the cystic duct. So the Cartilage triangle highlighted in the blue color there, it is between the cystic artery and the common hepatic duct and the cystic duct over there. Except the inferior surface of the liver, that is not forming the boundary. So remember 3 C's for the Cartilage triangle. Fine.